And thank you all so much for coming. Thank you, Cathy, for agreeing to do our training this month. I'm really excited. I've known Cathy for, I don't know, probably my whole life to some degree. We're from the same town in Kentucky. And Cathy is one of the most passionate humanitarians that I think I've ever met. So I'll go ahead and introduce her, and it is my absolute pleasure to introduce Cathy. As the Director of Inclusion and Diversity Engagement at Lincoln Memorial University in Harrogate, Tennessee. And before joining the staff at LMU in 2015, she was employed at the Children's Advocacy Center in Chattanooga, Tennessee, as External Affairs Coordinator, where she directed outreach communications and fund development initiatives. Cathy has a BA from Northern Kentucky University in organizational leadership with concentrations in communications and social issues, as well as a master's in public administration with a concentration in nonprofit management from Lincoln Memorial University. Professional memberships include the National Association of Diversity Officers in Higher Education, Student Affairs Administrators in Higher Education, and the Consortium of Higher Education LGBT Resource Professionals. She lives in Middlesboro, Kentucky with her husband Ismail, and enjoys traveling and spending time with their 3 children and 5-year-old grandson. And Eldahan is a passionate and proud ally and strong advocate for equity and social justice. So without further ado, Cathy, go ahead and take it away.
Thank you, Chloe. I really was honored when you asked me to participate in this. I've attended some of the workshops that you've had scheduled for us this fall, and I found all of them to be very helpful. So I appreciate the opportunity to be here today. The learning objectives are to increase your awareness of cultural competence in service agencies and professions, to identify the norms and values that influence culturally distinct behaviors and their impact on service outcomes, and to provide tips for improving quality of services through a culturally competent approach. And I'd like to say here that I am very flexible with presentations that I do. That's a big part of my job. And if you have any questions, please feel free to put them in the chat, and then Chloe will bring them up as you post them, and we'll address them in real time. So this presentation was actually developed a few years ago for when I was asked to lecture at LMU's medical school to their first-year students on cultural competency in healthcare. And since then, I've I've broadened it a little bit for service providers, social service providers, and in other areas as well. And so I always like to start out with definitions to cover just a few before we move on into the other part of the presentation. So culture is the integrated pattern of thoughts, communications, actions, customs, beliefs, values, and institutions associated either wholly or partially with racial, ethnic, or linguistic groups, as well as with religious, spiritual, biological, geographical, or sociological characteristics. That definition comes from the Office of Minority Health with the U.S. Department of Health and Human Services. Culture is dynamic in nature, and it's important to note that individuals may identify with multiple cultures over the course of their lifetime.
Hey, Cathy.
Yes.
A few people in the chat asked if you could make it full screen. I think that some of the font is just a little hard to read.
Okay. Give me a second to do that. Well, I'm having trouble finding where to do that because
just go under slideshow.
I know I can't find that because it's covered.
Oh.
The Zoom information is covering it. Let's see if I can just move across it without it. Yeah. Let me see if I can move this. Oh, I realize I could move that. There we go. There we go. Is that better?
That looks great. Thank you so much, Cathy.
Okay. Now let me get this out of the way. So the next definition then is multiculturalism, the recognition and acknowledgement that society is pluralistic. So in addition to the dominant culture that we have in any country, there's also the subcultures that exist around ethnicity and sexual orientation, geography, religion, gender, class, ability, and all those things. And then that then leads to intersectionality, which is multiple identities intersecting to create a whole that is different from the component identities. And I'll address that more in another slide as well. Let's see here. Not able. Okay. So cultural competence is the understanding of diverse attitudes, beliefs, behaviors, practices, and communication patterns attributable to a variety of factors. And the National Association of Social Work says that cultural competence requires self-awareness, cultural humility, and the commitment to understanding and embracing culture as central to effective practice. So when we talk about culture and the identities of individuals and of a community, it's a lot of different things. A lot of people, when they first think about it, think of national origin, geographic location, sexual orientation, race, religion, but it also lends to many other facets of a person's identity or community's makeup. So age, physical ability or limitations, health practices, socioeconomic status, job status, educational level, family and household composition, all these different things come together to make up an individual's identity as well as that of a community. So why is cultural competency important in service organizations? Well, for one thing, there are a lot of mandates and regulations that are prescribed. So the National Class Standards, which is through the Health and Human Services, which I'll address in more detail in the next slide, as well as the Affordable Care Act, better known as Obamacare, the Civil Rights Act of 1964, the Joint Commission, the National Association of Social Workers, as well as other professional organizations for those professions and services, social services. Also, you know, the changing demographics of the United States. In the 2010 census, 35% of those completing it self-identified as a racial or ethnic minority. So I'm interested in seeing how much that has changed in the last 10 years. But we know that health disparities exist among traditionally or historically underrepresented people. And that would be minorities, racial and ethnic minorities, also, you know, age, the LGBT community, specifically those who identify as transgender, all those groups, as well as others that, again, are historically underrepresented, that experience health disparities. We also have almost 37 million people in this country who speak English as a second language, or rather another language is spoken in their home. And of those 37 million, more than 24 are considered to be limited or to have limited English proficiency. And beyond those reasons, there's also a business imperative for being culturally competent. So it helps to create loyalty between your client or your patient. It helps to reduce no-shows. Those clients and patients who feel that their culture is being respected are more likely to show up at appointments on time. And that's just a good business imperative to, as well as building loyalty with you and spreading, you know, within their community, letting people know that these are good people. You know, I trust them, and then they'll come to you as well, hopefully. So I mentioned the class standards. That is a set of 15 action steps that were issued by the Department of Health and Human Services, culturally and linguistic appropriate services, intended to advance health equity and to improve quality and help eliminate healthcare disparities. The Joint Commission is the independent nonprofit that sets the standards for healthcare accreditation. The Civil Rights Act of 1964 prohibits discrimination in protected classes. So that includes race, color, religion, gender, national origin, and more recently, mental and physical ability, sexual orientation, and retaliation. Also, the Affordable Care Act, also known as Obamacare, has provided affordable health coverage to millions of Americans who had not been insured previously or have been underinsured. And we know that being uninsured or underinsured is a significant factor that contributes to health disparities. The National Association of Social Workers, which is the world's largest profession or professional organization for social workers, issued 10 standards and indicators for cultural competence in social work practice. So that includes ethics and values, self-awareness, cross-cultural knowledge and skills, service delivery, empowerment and advocacy, a diverse workforce, professional education, language and communication, and leadership to advance the cultural competence. And so cultural norms and values to take into consideration are time, timeliness, and time consciousness. There are cultures around the world who view time much differently than we view it in the United States. My husband is from Egypt, and that part of the world views time differently. They kind of see time as a suggestion rather than a set time for something to begin or end. And plenty of cultures around the country or around the world see time in that same manner. Also focus on relationships, family and friends, valuing individual over group and harmony over conflict. We're seeing a really obvious example right now of how in the United States, we're an individualistic society. We have so many people who refuse to wear a mask to help protect the others in their community. And that's a sign of an individualistic society. Other parts of the world have more emphasis on group well-being, community well-being. A sense of self and space and physical contact with others. Some have, and this can be individual or it can be a cultural issue. We don't like our space to be invaded sometimes. I don't like my space, so I don't want people to come too close to me and invade my personal space. But that can be, it can relate to a person's culture as well as their own individual preference. Communication and language, work habits and practices, health beliefs and practices, beliefs and attitudes about authority, control, and fate, adherence to prescribed gender roles, and then mental processing and learning styles. Those are all some of the cultural norms and values that anyone in healthcare or any kind of social service agency should be taking into consideration as they prepare for the treatment plans and just interactions with their clients and patients. I'm gonna take a drink. Has anyone read this book? The Spirit Catches You and You Fall Down. Do we have anyone who's ever read it? Well, I'm going to highly recommend it, but I'm also going to give a spoiler on it. It is an ethnography about a family, a Hmong family who migrated to the United States following the Vietnam War. They came here from a refugee camp in 1979, and they settled in a town in California, Merced, California. And the book is, it really gives a very sad, but a really good example of how two cultures can clash when it comes to providing healthcare and services to an individual. So I've read this book 2 or 3 times already, but just to make sure I don't leave anything out, I have a timeline that I'm going to read from. As I mentioned, it's an ethnography and it takes a deep look at the Hmong culture. If you're not familiar with that, the Hmong culture is a Southeast Asian ethnic group coming from China, coming from Thailand, Vietnam, that area of the world. And the book goes back over many generations of Hmong culture, even a few hundred generations. The family, as I said, they came to the US in 1979. They settled in Merced, California. At that time, Merced, California was comprised of approximately 1/6 Hmong population. So a lot of the refugees coming to the US settled in that area at that time. And their daughter, Leah, was born in Merced. She was the first child that they had born in the US. She's actually the 5th child of 14, but she was the first to be born in the US. She was born in 1982, and she was a healthy child. She had a good APGAR score, and for all intents and purposes, she was healthy. When she was 3 months old, her sister came in from school and slammed the door to their apartment. And Leah then had a seizure. Well, her parents immediately suspected that the loud sound frightened Leah so much that her soul fled her body. And that's a phenomenon known in the Hmong culture as kao da pei, which means the spirit catches you and you fall down, hence the title of the book. But in English and in medical terms, that means epilepsy. In contrast to how Western medicine approaches this condition, traditional Hmong belief views it as they do with many illnesses, and that's that it's spiritual in origin, and it's caused when the soul becomes separated from the body. A traditional Hmong cure might include visits from a shaman, which is a divine or ancient healer, and they would then attempt to reunite the body with the soul. However, the Hmong culture also believes that kao da pei brings a person distinction, as seizures are often deemed people fit for divine office, and those who are afflicted and healed may be destined to become shamans themselves. Regardless, her parents rushed her to the hospital. Neither parent spoke English, and communication was very difficult with the physician. There was no interpreter available, and the resident on duty misdiagnosed Leah with pneumonia. She continued having seizures and made over 20 visits to the hospital in just a few months. Her seizures worsened, and after learning that the Leahs weren't giving Leah her medication properly, the pediatrician reported to Child Protective Services, and she was placed into foster care. At that time, she was approximately 3 years old, and she continued having seizures, though, while in foster care. She stayed in foster care for approximately a year, and during that time, her parents befriended the foster mom, and she became witness to the love and the devotion that the Leahs had for their daughter. She also became aware of the cultural implications that were impeding their abilities to understand the treatment plans that the physicians had for Leah. So the foster mom then started pushing to have Leah reunited with her family. And she was eventually reunited. And at that time, social workers then worked with the parents to help them understand dosaging. They were illiterate in both English and their Hmong language, so they did not understand the dosing, their concept of time. They had no clocks in their home. Their concept of time was based on the sun. And so if you can imagine how someone who doesn't read or write either language and uses their concept of time being based on the sun, how are they going to give a teaspoon of medicine every 4 hours, for example? But even once they had the social worker working with them and she was receiving her medication from them in the home, she continued to have the seizures, and they were just getting worse. By the age of 4, Leah had had more than 100 outpatient visits to medical facilities, and she'd been admitted to the hospital 17 times. And as you'd expect, her development had noticeably slowed at that point. When she was 4.5, she had a catastrophic seizure that lasted nearly 2 hours. She developed an infection that turned septic, and by the end of the day, she was determined to be brain dead. Her physicians predicted that she would die within days, and they allowed the family to take her home so that she could be surrounded by her family. The parents, being desperate, they invited the shaman back into their home to perform another need ceremony to bring her soul back to her body. Most patients are in vegetative state for 3 to 5 years. Leah's parents, though, somehow managed to keep their daughter alive much longer. She actually lived to be 30 years old. So for 26 years, Leah's days varied little. Her parents bathed her, they fed her, they flexed her stiffened limbs, they kissed her and caressed her and talked tenderly to her. She was surrounded by love always. There were still visits to doctors, and there were still periodic visits from the shaman, but at that point they were intended not so much to cure Leah as to ease her suffering. And Leah died at the age of 30, just about a month after her 30th birthday. So no one knows really, could things have gone differently for Leah? Would they have ended the way that they did had there been someone there to diagnose her correctly from the beginning and to understand from the beginning what the impediments were with the parents' abilities to follow through with the treatment plan? No one really knows, but this family's story is a very good, it gives very good insight into what can happen when cultures clash in that way. The response in Merced County was that they formed a social service agency to train medical interpreters in a half dozen languages. Leah's siblings, children, had been called in to interpret for her parents when there was an interpreter available. Merced County Hospital had also started, as response, started allowing Hmong shamans to visit their patients and to practice a limited number of their healing traditions in the hospital. And the book itself has become a widely assigned reading in many medical and healthcare schools, as well as in courses for public health, social work, anthropology, and journalism, and sociology and other disciplines as well. I have given you a spoiler on it, but I assure you that the book is so much more detailed. And if you have any interest at all in reading it, knowing the outcome of Leah's situation and the response from the community, really won't limit what you get out of reading the book. You'll want to just get more of it if you decide to read it yourself. So in becoming culturally competent, I have now some considerations for your personal and professional practice. And first, we have to know others, we have to first know ourselves. So we always have to start with self-reflection and self-awareness. And from there, our cultural competence is going to grow with the knowledge that we continue to receive. It's going to be enhanced with specific skills, and it's going to be polished through the various cross-cultural experiences that you'll have. So in self-reflecting, getting to know yourself, ask yourself these questions. What were some of the values in your family around health and community? What were some of the beliefs and healing methods used? You know, in my family, I was brought up in Middlesboro, as Chloe mentioned, where we're both from. My parents and a lot of people still do this. Anytime we had a sore throat, mom and dad said gargle with hot salt water. If you had a little cut or sore from a bike ride or something where we had an accident and scraped our knee, soak a rag in warm salt water to prevent infection or to draw infection out. What kinds of things did your family, what kinds of practices did your family use that were similar? What ethnic group or socioeconomic class or religion or age group or community do you belong to? What was your first experience with people from a different ethnic group or religion or age group or community, not your own? For myself, I think back to the first time that I was aware of someone being a different background from my own was when I saw the nuns from the Catholic school dressed in full habit and walking down the sidewalk or out in the play yard with their students. I didn't go to the Catholic school, but I saw that as a young child and I was so intrigued. A few years later, I recall being in a store with my parents and seeing a family all dressed in beautiful, colorful, flowing fabric. And now I assumed that that was probably a Southeast Asian family that I had seen. And again, I was intrigued by that. So what was your first experience, and then what was that experience like for you? Was it positive or was it something negative? What sociocultural factors in your background might contribute to your being rejected by others? Something that comes to my mind with myself and my family is, being from Appalachia, being from the South, we have a distinct accent. All three of my kids went away to schools in the North and Northeast. We had one in Ohio, one in Connecticut, and one in Washington, D.C. And all of them commented about, as soon as someone heard them speak, there were always comments about it. Oh, say that again. Oh, your accent is so cute. My daughter even related it to feeling being exoticized because her accent from being from Appalachia or Southern accent. And that, for a lot of us who have that strong Southern accent or Appalachian accent, when we're speaking to someone who's not got that accent, lots of times they automatically dismiss us as being uneducated. And so that could, lead to being rejected in a job, for example. Also, have you experienced prejudice from others? What personal qualities do you have that will help you establish interpersonal relationships from other cultural groups? What personal qualities may be a detriment to having or building good relationships with others from cultural groups? Also ask yourself these questions. Who are your clients? Who are your patients? Who are their families? How can you learn about them, and what are your beliefs about this group? Do you have implicit biases toward this group? We all have implicit biases. They start developing as early as age 3 or 4, and based on all the information that we receive from our environment and from the people who are around us and from the media that we see and hear day in and day out. We all have them. There's the first part in reversing our biases is to be aware of them and to have an understanding about how they developed. Also, ask questions, listen, account for any language issues, and be aware of the different communication styles. Culturally competent services are sensitive to personal health beliefs and practices. Cultural or customary rituals or people used to treat the illness, such as the shamans. Will the client or patient follow through? With Leah's family, they also, in addition to not understanding how to administer the medication, they did also have a conflict in that they thought that their daughter could be destined for being a higher, a higher power, a higher authority, someone who could become a healer, and that was a feeling that they were happy about. So that also was an interference in how they were able. They weren't always sure, and then also they thought that it was making her sicker. When they did give her the medication. Is the patient taking other medicines or anything else to help them feel well? Have they gargled with salt water? Has their family gone out and collected herbs to help to deal with the illness or before they've been brought into a clinic, for example? Who makes the decisions in the family? Are illnesses treated at home or by community members, such as the shaman? And what is the perception of mental health needs and treatment for that cultural background. Culturally competent services are also sensitive to language barriers. So does the client or the patient understand English? What is their literacy level? Leah's parents, again, they were illiterate in both English and the Hmong language. So use visual aids and demonstrate procedures. And that's exactly what the social worker did with Leah's parents when she was placed back in their home after foster care. She put clocks on the wall. She made posters on the wall that showed the times, and they got a digital clock. And she posted the times on the poster so that when the clock read what was on the wall, they knew that it was time to give her medication. They marked the instruments that they used to measure out her medication for the proper dosages. And then check for understanding, and that's just a good habit to be in with any kind of communication, is always to make sure that what you have said to someone is transcribed with the way that you meant it to be. So check for understanding, and then ask if an interpreter is necessary. Also, culturally competent services consider body language, so eye contact. There are some cultures where eye contact is not made. There are some people who will avert their attention or avert their eyes from and not make eye contact, and that's considered respectful. It's also considered disrespectful in some cultures. Touching, invading personal space, privacy and modesty. There are some women in the Islamic faith, not all, but some who will who prefer to have a female physician or someone providing services to them who's female. Also consider gender identity, sexual orientation, wealth or social status, and the presence of a physical or mental disability. Culturally competent services also consider religious and spiritual factors. Are there sensitivities and beliefs associated with birth or death? Are there certain treatments or blood products that the family or individual would refuse? How is prayer or medication and worship, how are those used and how are they viewed? Food preparation and the use of food preparation in healing or celebrations. When Leah was born, she was born in the hospital in California, and it was the first time, as I recall, that the family had experienced American foods through the cafeteria food at the hospital, and they didn't know what it was. It certainly wasn't anything that tempted them. And so her family, the mother, Mrs. Lee, the family brought her food that they had prepared and that some of the community members had prepared for her. Traditional foods that were fed to or given to a mother after giving birth that would help bring her strength back. The doctors and the other staff in the hospital noted in the book that how perverse the smell of that food was to them. I don't know exactly what it was, but it was different for them, and they viewed it in a negative way. Clothing, animals, or special objects. Is there anything like that that a culture may consider important? And then also the gender practices. So culturally competent services convey respect. You build rapport and trust with your client or your patient. Explain why you must ask personal or sensitive questions. And I think this is a good place to say also pronouns, making the use of pronouns normalized, introducing yourself with your pronouns. And I failed to do that at the beginning, but my pronouns are she, her, and hers. But when we start any kind of introduction off that way, then it normalizes it. And anyone whose gender identity doesn't match with their biological, then that's going to help them feel more comfortable. Also, watch for clients, patients' verbal and nonverbal cues. Allow the client or patient to ask questions at frequent intervals, because if they are in a healthcare situation or a situation where they're receiving social services, they're probably feeling very overwhelmed. And even in someone who is proficient in English, it's a good opportunity to stop at frequent intervals to give them an opportunity to ask questions. And then practice polite and respectful communication and give your time and attention when communicating. When I do this presentation, what always comes to my mind with that is when I had attended a doctor's appointment with my sister. who had colon cancer. And this was at the end of her first year of treatment. And when she was supposed to have been considered free of and cleared of cancer after a year of chemotherapy and radiation, her physician had not looked at her chart from the reports that he had gotten from tests that she had had prior to that appointment. So he's sitting at his computer in the room, and we're both sitting there, and he's reading the reports, and he starts saying, oh no, this is bad. This is the worst of the worst. And he turns around and he looks at my sister and says, you may not be around at Christmas. Well, she was around for 6 more years. His reaction, I'm sure, was he was shocked himself. He hadn't read the report before he came into the room to see my sister, and he was just as distraught by reading it as we were to hear it. But the way that he communicated that to her was terribly overwhelming for her and for me as well. But thankfully, you know, she did persevere, and we had her for another 6 years. But that was a horrifying experience for both of us. Acknowledge non-traditional living situations and family structures. Don't ask about immigration status unless you're an organization who provides services for immigration. Otherwise, it's really not necessary. Asking that question, if someone is here who is undocumented, they're probably not going to trust you. They may not be truthful with you. And they likely won't return for any of the services that they're needing from your agency. Provide appropriate health education and service information. Let them know what to expect along the way. There's a video out there about a young woman who was from, I think she was from Ethiopia, and she had only been here a few months, and she was pregnant, and she had an appointment with for the first time with a healthcare provider. And by her culture, arriving at a specific time was something that wasn't as important. So she had a lot to do that day. She did her tasks before getting there for her appointment at, I think it was 5:30, and the office had closed at 4:30. And so when she called the next day, you know, they were a little bit short with her because she had not shown up for her appointment. But for her, it wasn't anything rude or anything unusual based on her culture. Work with an interpreter when necessary. The physicians, the healthcare providers, and the social workers that worked with the Lee family often ended up using her siblings for translators, other children for translators. But there's so much that is lost when medical information is being interpreted by someone who isn't trained in that. And so avoid the use of family or non-medically trained staff, and keep a list of interpreters and schedule your clients and patients accordingly. And at the very least, there are interpreting agencies that you can subscribe to. My son is a nurse practitioner in New York City, and most of his clients are Hispanic and speak Spanish. He doesn't. And so often he ends up using the dial-in service that they have and putting it on so that they can all hear the conversation, putting it on speakerphone. So there are lots of services available like that now if you don't have interpreters in your area. And obviously you would want a service that you know, is going to provide for the languages that are most commonly spoken in your area outside of English. So wrapping up, cultural respect has a positive effect on patient care and service delivery by enabling providers to deliver services that are respectful of and responsive to the health beliefs, practices, and cultural and linguistic needs of diverse patients. And that comes from the U.S. Department of Health and Human Services. Being culturally competent does not mean that you are an authority on all of the values and all the cultures that are out there. That's absolutely impossible. But what it does mean is that we are willing to learn and willing to open to understanding that there are many ways of viewing the world. So showing respect and being willing to learn, and understanding that you know, there's not just one way, there are many ways of viewing the world in traveling through this life. So with that, I'll open up the questions. Looks like we have a few. I don't know how much time we have, Chloe. How much time do we have?
You're fine. You've still got about 20 minutes.
Oh, okay. I'm trying to open up chat here.
Well, Tina and I were talking about how we also gargle with salt water.
Surely we're not the only ones, though, in a group of 11 people. You know, and it works. If you can stand to get it, I can't stand to get it in my mouth that way, but it does work. Okay, let's see, what do we have here? Is there anything else? I see the, okay. Okay, so that's all we had then. Well, I appreciate everybody's attending this today. I hope that you found something useful in it. If I can ever be of help to you, I may not always have the answers, but I'll certainly work hard to find them for you. Feel free to reach out to me at wanda.eldahan@lmunet.edu. My name is Cathy, but LMU insists on using our first name on our Social Security, and I go by a shortened version of my middle name, so it confuses people, but wanda.eldahan@lmunet.edu. If any of you would like to have a copy of this presentation, I'll be happy to send that to you. If you just want to let Chloe know or send me an email, I'll be happy to share it. But if we don't have any questions, then this concludes the presentation.
Thank you so much, Cathy. And everybody, I think I'll have everybody's emails just because of the registration for the Zoom link, but there will be a survey sent out either later this week or beginning of next week. So keep an eye out for that.
Thank you, Chloe, for mentioning that. I forgot about it.
Yeah, no problem. All right. Thank you all so much. And thank you so much, Cathy. This was wonderful.
Thank you. I appreciate the opportunity. Everybody stay safe out there.
Bye, everybody.
Thanks. Bye-bye.